Good morning, good afternoon, everybody. Welcome to another presentation in the CanFASD webinar series. Today's presentation is called Pain as Experienced by Individuals with FASD. For those of you who are not familiar with the CanFASD Research Network, it's a national not-for-profit organization that works towards all Canadians engaged and untied with awareness, evidence, and knowledge that are effectively addressing the complexities of FASD. CanFASD turns research and evidence into meaningful resources and tools to support individuals, policies, and practices. So I am thrilled to be here as the host for today's webinar. My name is Dr. Kathryn Birnie. I am a clinical psychologist and an assistant professor at the University of Calgary. I do a lot of research and practice in partnership with youth and their families in the area of pain. I'm also assistant scientific director of an organization called Solutions for Kids in Pain that I'm looking forward to sharing a bit with you about in a few minutes. But just also really thrilled to be here with you today and to learn from our three exceptional speakers over the course of our webinar. Just before we begin, I want to respectfully acknowledge that across Canada we live in various treaty territories and traditional meeting grounds and homes of the Indigenous people and Métis. I would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. And the city of Calgary, where I am today, is also home to Métis Nation of Alberta Region 3. So as I mentioned, I'm assistant scientific director of an organization called Solutions for Kids in Pain. And our goal is we're a national not-for-profit organization that really seeks to bridge that gap between existing research and evidence that exists about managing pain in children and what's actually happens kind of day to day, really empowering parents and families and youth themselves with knowledge about managing pain, but also healthcare professionals and health institutions across the country. So we really work closely in partnership. We have a hub and spoke model where we've got regional centers that bridge out and make connections to various places across the country. And I'm just going to show you a brief video about SKIP because I think it looks a lot more exciting than listening to me just talk about it.
Canada is a world leader in children's pain research. But did you know it can take up to 17 years for research findings to be put into practice? That's a whole generation of children who miss out on the benefits of information we already know. What we know now is that 2 out of 3 children in hospital undergo painful procedures without any pain management at all. 75% of parents say they don't know how to manage their children's pain. Veterinarians get 5 times more training in pain than people doctors. And only a few Canadian health institutions have made a certified commitment to better pain management. This matters because pain that isn't treated well harms children's brains and bodies, is a struggle and can be traumatic for families and health professionals, and costs the healthcare system time and money. Scientists have found many ways to manage pain, but most people don't know about these treatments. That's why at Solutions for Kids in Pain, or SKIP, we are working to improve children's pain management across Canada. We are a national knowledge mobilization network that is bringing together researchers, patients and caregivers, health professionals, 48 different health institutions, including all the children's hospitals in Canada, and over 100 partners from around the world. Our goal is to get knowledge about children's pain into the hands of people who need it faster. If you're a scientist or researcher, patient, caregiver, health professional, policymaker, or part of an organization or company with unique expertise or technology, you can help. In fact, anyone can. We all have the opportunity to be a champion for kids in pain. Visit kidsinpain.ca to find out how you can get involved.
So we've got a great team, some of us up there across the country. We have these 4 regional hubs I mentioned, one in Western Canada in Edmonton, 2 in Central Canada, one in Ottawa, one in Toronto, and one on the East Coast in Halifax. And we've got full-time knowledge brokers. So their full-time job is making sure research evidence is getting into the hands of people who need it every day. We're also what's called a patients included organization. So we have people with pain during childhood or as parents and caregivers involved in everything we do, from our board of directors to within our staff in our organization to engaging in different activities that we're doing in the community and with children's healthcare institutions. We got a lot of partners we're doing all this work with. It's all about connection and partnership to make a difference. And if you're interested in getting involved, please feel free to reach out. We have a newsletter, we are on social media, and would love to connect further with everyone. So without further ado, I would like to introduce our first speaker. So I mentioned that Dr. Kyle Sue is a family physician in Edmonton, and he splits his time between the University of Alberta's Division of Developmental Pediatrics and Division of IHOPE, Immunology, Hematology, Oncology, Palliative Care, and Environmental Medicine. And within developmental pediatrics, he works in the Pediatric FASD Assessment Service, the Infant and Preschool Assessment Service, and the School Age Neurodevelopmental Assessment Clinic. Within IHOPE, he works with the ASSIST program at the Stollery Children's Hospital, which stands for Aid for Symptoms and Serious Illness Support Team. He's also a rural remote general practitioner. Dr. Sue's done lots of things. He completed his rural family medicine residency at Memorial University of Newfoundland, 2 fellowships in developmental disabilities at Queen's and the University of British Columbia, and a fellowship in pediatric pain medicine at the University of British Columbia, and 1 in adult and pediatric palliative care at the University of Ottawa. So he's worked across the country as well as internationally, and he's won numerous awards for his research, leadership, and clinical work. So with that, I'll turn it over to you, Kyle.
Well, thank you very much for that introduction. As Katie said, I'm mostly based in Edmonton. I spend 80% of my time here, but I'll spend 20% of my time in the Northwest Territories as a family doctor. Can everyone hear me okay? All right, perfect. All right, so let me get started. Here we go. So I have no relationships with any financial sponsors to declare. So let's start with the basics. What is pain? Well, pain is your body's alarm system. It alerts you to danger and potential or actual tissue damage. So essentially, you get these pain signals coming from your peripheral sensory nerves, and well, it actually starts as, just yourself feeling, sensations. So whether that's pressure or touch, and once it goes beyond a certain threshold, then your body will interpret that as pain. And so everybody has a different sensitivity to their alarm system. So similar to, say, your car alarm, some cars have very sensitive car alarms where you can just walk by the car and the alarm goes off. There are other cars where you have to really jolt it before the alarm goes off. So it's the same for humans. Everybody has different threshold or sensitivity. So pain is a perception of the brain. Without the brain, there isn't pain. So for some people, for example, people who have a stroke in a certain part of the brain, they can have a centrally based pain. So their brain tells them that they are having pain in various parts of their body, even though those parts of the body actually have nothing wrong with them. And in fact, those signals are coming from the brain itself. And for some people with stroke, if certain parts of the brain are damaged to a certain point, they may not even be able to feel the sensation of pain. So I struggled a bit with how to explain pain signaling, given the very wide backgrounds of our audience. But in a nutshell, our nervous system is comprised of the central nervous system, which is our brain and our spinal cord, and our peripheral nervous system. So there's both an up transmission from our peripheral nerves up to our brain, as well as a downwards transmission from our brain back out to the periphery. So as I've talked about already, a signal can start at your peripheral nerve. A noxious stimuli can be detected, and that signal will travel up the nerve, the dorsal root ganglion in the spinal cord. And it'll go up the spinal cord, all the way to the brain, to various parts like the frontal cortex, the thalamus, anterior cingulate cortex, with input from the amygdala based off of emotions, memories, anxiety, etc. And then your brain will then process that information in order to determine what to do next. So in a situation, for example, where you're in great danger, let's say you're in the battlefield and you just had your arm blown off, well, your brain will then send down inhibitory signals to dampen down the pain signaling from the periphery, so that your brain can focus more on escaping the danger. Compared to another situation where, let's say your hand is on a hot stove, your brain will want to tell itself to take your hand off the hot stove. So it'll send signals back down to the periphery, increasing the amount of signaling coming in, so the pain increases and increases and increases until you take your hand off the stove. So in a nutshell, that's how pain signaling works. However, there are a lot of modulating factors that determine how much pain is being felt. And in a way, it kind of works like a tug of war. The various components that act against each other and determine how much pain you're feeling. So you may have heard of endorphins, which are a type of endogenous opioid that your body makes. Likewise, enkephalins and dynorphins are also endogenous opioids that will decrease the amount of pain that you're feeling. Likewise, dopamine and serotonin also help decrease the amount of pain that you feel. On the other hand, we have glutamate and immune cells that can increase the amount of pain that is felt. So often with pain comes inflammation. And so with inflammation, the immune system is acting and is sending pro-inflammatory signals, and is also priming certain immune cells, as in preparing immune cells to produce more pain-inducing chemicals, both immediately as well as in the future. So as an analogy, it's kind of like small roads feeding into the spinal cord highway. And there are factors that can dampen down the signals or the number of cars coming in periphery onto the highway. And so those would be the endogenous opioids, the dopamine, norepinephrine, serotonin. It's like radio traffic reports advising cars to avoid the highway due to construction. So therefore, you'll have less signals or cars onto that highway. But there are factors that can work against that. For example, the construction's done, the barriers are removed, or the HOV lane's opened. Well, now you have a lot more cars going to the highway, and that's increasing the signals. So immune cells and glutamate act in that respect. So as you can see, the nervous system has a lot of factors that determine how much pain is being felt. It is a very changeable system. So we call that neuroplasticity. So the reason why in chronic pain, it is so difficult to treat often is because we retrain both the driver as well as change all the various facilitators and inhibitors en route to decrease the amount of pain or decrease the sensitivity of the alarm that has become hypersensitive. And along those lines as well, once, the cells are used to taking a certain route, for example, if you can imagine yourself driving to work the same way every day, sometimes even on a weekend, maybe you're just not thinking that, oh, I'm actually driving to the farmer's market today and not, but your brain just goes in overdrive and just puts you on that same route again because you're used to it. So in terms of the pain signaling system, it can work like that as well. So in terms of functional MRI, this just basically shows what I've described, where again and again, and the same parts of the brain or nervous system will light up. In terms of treatment of pain using medications, one of the reasons it's so difficult to completely take away pain for people who have pain disorders is because there's so many different components involved. And as I mentioned, it's a bit of a tug of war. And so each medication that we have works on a different aspect of it. And often we need a combination of it in order to. So let's talk about how prenatal alcohol disrupts pain signaling. So first, I'm going to talk about dopamine. So in a study on rhesus monkeys, it's been shown that alcohol exposure prenatally changes the availability of dopamine receptors in the body, as well as how sensitive those receptors are to dopamine. And it seems to change actually depending on when during gestation the alcohol is ingested. So in this study, for the monkeys who ingested alcohol early gestation or continuously during the pregnancy, there were fewer dopamine receptors at the nerve synapses. But the opposite effect was seen for those who were exposed to alcohol mid to late gestation. So serotonin, like dopamine, is heavily involved in pain modulation. And there's a very close connection between the stress response in the body and serotonin. So as many of you know, cortisol is a stress hormone that's produced by the body and is affected by the hypothalamic pituitary adrenal axis. And that is closely connected to the serotonin levels in our body as well. And so there's been a study of newborns that shows that prenatal alcohol exposure actually leads to a lower stress response to a heel poke. And they postulate that is because of changes in the serotonin levels during critical periods of brain development. But on the other hand, another study showed that prenatal alcohol exposure leads to less serotonin release by the nerves. And so one mechanism basically decreases the amount of pain that someone should be feeling, and one increases it. So again, it's a bit of a tug of war as to what happens. So anxiety and mood are closely correlated with feelings of pain. So as many people stress, our cortisol levels go up, and that actually depresses our immune system. For example, we're more likely to catch a cold or get any kind of infection. Well, because the immune system is so closely interconnected to pain signaling, it'll also affect how much pain one feels. And as I've mentioned already, dopamine, serotonin, and norepinephrine are hugely involved in pain modulation as well. And when they're released by the rostral-ventral medulla and the periaqueductal gray, it can decrease the amount of pain signaling that's happening. And this is closely intertwined with the stress response. And as I mentioned earlier, the amygdala in the brain also contributes to this. So for people with FASD, there was one study that showed that 91% of people with FASD have actual electrophysiologic abnormalities of the peripheral nerves. So meaning that the electrical conduction in those nerves is actually not normal. And on another study that Myles is going to talk about after this, close to 87% of people with FASD in that study reported having an inappropriate pain sensation, whether that was a very high pain tolerance or a very low tolerance. We see the same in mice and rat studies. So in one mouse study, prenatal alcohol exposure led to the offspring being more sensitive to pains. When their paws were put on a hot plate, they removed their paws from the hot plate a lot quicker than those who were not prenatally exposed. But on the other hand, there was a study in rats that showed that prenatal alcohol decreased the number of sensory neurons in the trigeminal nerves in the face by 27%. So because there's decreased sensation, therefore, there should be decreased pain signaling as well. However, it's not that simple. There are changes in tolerance over time as well. So in another study with moderate prenatal alcohol exposure, they found that in the kids, before having any physical trauma, they actually had no overt sensitivity to touch. But after even having a minor nerve injury, that primed them or set them up for future hypersensitivity, where even light touch felt more painful. And in those cases, the magnitude of the response to future insults is disproportionately greater than the degree of the insult itself. So a light touch should not be painful. You know, the alarm system is now being too sensitive. Also, the priming of the peripheral cells, as I said earlier, they seem to have a memory of this previous insult. So the next time that there's an insult, there's more inflammatory chemicals that are released. So the brain has learned, the nervous system has learned, and now is always on high alert. And this sets people with FASD up for having chronic pain. So on a study that Myles will talk about, 3% of people in the study had chronic migraines, compared to 12 to 16% of the general population. That's more than double. So it's not just the pain signaling that's affected, but also the responses to pain medications. So in 1986, there was a study in rats that showed that prenatal exposure to alcohol made the offspring more sensitive to morphine. So the morphine was actually a lot stronger than for people who were not prenatally exposed. But that also meant not only analgesic effects, but they also had higher side effects as well. Likewise, medications like ketamine or methadone that rely on the NMDA receptors, it's been shown that there's a reduced density of NMDA binding sites. Overall, more alcohol means more impairment. And that's not just with pain, but also other aspects of sensory processing, like vision, smell, and taste. So my key points are, prenatal alcohol almost universally affects pain perception and tolerance, whether that's very high pain tolerance or very low. Again, it's a bit of a tug of war between the various factors that are involved. And prenatal alcohol affects pain modulation throughout life via the multiple mechanisms. So even if one starts with a high pain tolerance, it's still, they're still at risk for having future chronic pain. It'll affect their responses to pain medications. The timing of alcohol during the pregnancy might matter as well. And more alcohol means more impairment. But there are my references. Thank you.
Wonderful. Thank you very much, Dr. Sue, for that description, really about how prenatal alcohol exposure alters both like kind of directly, kind of how the nervous system is functioning in response to pain, but also other considerations or implications that can happen because of prenatal alcohol exposure, how it impacts other areas of functioning that also impact pain, whether that's our stress response or otherwise. So thank you very much for that. And just a reminder, yes, I see a few questions coming into the Q&A for Dr. Sue, so please keep those coming for all of the speakers, and we'll ask those at the end. So our next speaker for today is Myles Himmelreich. Myles is a well-known motivational speaker. He's presented nationally and internationally for many years, sharing his personal strategies and techniques for FASD. And he's done a great deal of work as a consultant to many different agencies and organizations dealing with criminal justice systems, teachers, support professionals, paraprofessionals, caregivers, doctors, and most importantly, parents and individuals with disabilities themselves. Myles was also co-lead of a groundbreaking study on the health and physical issues of adults with FASD. His goal is to bring awareness, acceptance, and a true understanding of living with a disability to his audiences. I'll turn it over to you, Myles.
Thank you. So good morning or afternoon, evening, wherever you may be. Today, I'm going to share a little bit about the health study that myself, CJ, and Emily were co-leads on putting together. And one of the reasons that we ended up doing this health survey was because as we were at these different FASD conferences, we started realizing that there was a lot of focus on the brain development, and the impact that alcohol has on the brain development. But what we also realized too in our time together was that we started noticing we had a lot of similar health issues. And not only were there some that were similar, but the number of health issues that we had were quite high. So it wasn't one or two things. At one point, we ended up, between myself, CJ, and Emily, sitting down and writing out a list of our health issues that we have. And we all had a couple pages worth of stuff that we were dealing with. For myself, I have hip dysplasia, scoliosis, osteoarthritis. I have arthritis in my knees, my ankles, degenerative disc disease in my neck, number of different health things. And so we thought it's interesting that just out of the three of us, there's so many different health issues that we're experiencing. And so we started to format this health survey, and we ended up getting it out to over 500 responses came back from all over the world. And in the survey, we asked questions about, there was over 260 questions in more than 25 areas, such as autoimmune, cardiovascular, hearing, many different things. And so when we got the stats back, what we did was we took the responses of people that said, yes, I have this health issue, and we put it to the comparison of general population of people that experience that health issue. And then we found out what the percentage was when it came to individuals with FASD compared to general population. So there's a few very telling things about this survey. One of them was the average age of people reporting having specific health issues was 27 and a half years of age. Now that's really important because the health issues that we're talking about, many of them were things that you wouldn't think to look at somebody who's in their 20s for, you know, and so when we got this information back, it was very telling. Some of the things that we found were things like early onset dementia, right? So early onset dementia, you look at around the age of 65. We had people in their 30s reporting on having early onset dementia. Now, again, these numbers are all from people who have an actual diagnosis of FASD. So people in their 30s that have FASD were having early onset dementia. We had women reporting in their 20s, having gone through or going through premenopause or full menopause. And we also had things like chronic ear infections among adults was over 147 times higher. 147 times higher for individuals with FASD to experience chronic ear infections. So as we were going through this, we asked, like I said, a variety of different health things, but we also asked about some sensory stuff. And as Dr. Sue talked about, we talked about pain tolerance. And so over 50% of people said they had a high pain tolerance. Over 30% of people said they had a low pain tolerance. So when Dr. Sue was talking, it was very interesting to kind of put together the fact that the way that the brain interprets pain affects the way that we react to it, and how we can have high pain tolerance in some areas and low in others, right? And so that makes it really difficult to simply say, oh, I have a high pain tolerance or I have a low pain tolerance, right? It's very individualized on the things that we're experiencing. The other thing that I think makes it really hard to express where our pain tolerance is and what is going on for us health-wise is the discomfort that I've had from my scoliosis and my arthritis and my hip dysplasia is discomfort and pain that I've had since I was a young teenager. So for me, it's been my normal. So I've always felt that discomfort, and I always thought, well, that's how everyone feels. Is it's hard to, lay one way because your back gets sore, or it's hard to walk some days. And when I was a teenager, it was quite often dismissed as, oh, he's just having growing pains, he's very active, whatever it is. And so, of course, as a child, I just believed that that must be the case, because we don't think, oh, well, let's take a 12-year-old in to get them checked for osteoarthritis. But I had osteoarthritis at the age of 12, right? And so quite often it was dismissed, and quite often I heard you're too young to have this, right? And then as I got into my 30s and I really started pushing more to the doctors that, no, I really have to look at this. It was interesting sitting in the waiting rooms with people that were in their 60s, 70s, 80s, talking about, oh man, it's just so hard to get out of bed today, and oh, this constant pain that I'm in. And I'm sitting there thinking, I hear ya. But they're looking at me going, what is this 30-year-old doing here, right? So it was really interesting to put together from this health survey that obviously the intake of alcohol during the pregnancy is affecting the way that not only our brain develops, because we know a lot about that, but also the way that our bodies are developing and the pain sensitivity that we're having. So, it would make sense that the alcohol doesn't simply just go up past the bones and the muscles and the nerves and stuff and go, okay, excuse me, bones and muscles and nerves, I'm just going to affect the brain. It's obviously affecting the development of those things as well. So looking at FASD as a whole body diagnosis is really important, because we need to know how that's playing a role for the individual, right? And we need to know what to look at when we're going in to the doctor, right? So the importance of understanding that our bodies are affected at a much younger age when it comes to the health issues, right? And so one of the reasons that we did this health survey was because we thought it was really important for parents and caregivers to know that when you do have a 12-year-old that's complaining of knee pain or back pain or whatever, they may not just be complaining all the time. There may actually be something there that we need to take our young children into the doctor to get looked at a quote unquote younger age than they should be, right? Because this is something that we're finding is very normal for many individuals with FASD. And since doing the health survey, presenting it back in 2017, we've had the opportunity to work with some other people, and it's been published. I believe the publication is going to be put on the notes here today, I believe. And also too, one of the things that we found when doing this health survey presentation was that many individuals, as well as parents and caregivers, were acknowledging the fact that yes, this is happening for this individual or for myself, right? So it's very important that this needs to be looked at when we talk about FASD, not simply about the brain development and where they are in life in regards to that, but also pain management and the different health issues, because it can make such a huge impact on somebody's life if we're living in constant pain and we don't know, because that's always been our normal, right? So thank you so much for this opportunity. The health survey itself, like I said, is published, and in the new year, CJ and I will actually be doing health survey presentation of the one that we did. I haven't really told CJ that yet, but anyways, so just to give more information and share more of the specific stats, but we wanted today to just kind of go along with what the discussion is in regards to pain and kind of help say that yes, from the research we found, it's really important to pay attention to this. So thank you so much for your time.
Thank you so much, Myles, for that presentation and overview of FASD and health issues generally. You know, today we're really focused on pain, but of course, pain is one aspect of many, many things, and also people are more than any one particular thing, right?
Mm-hmm.
So appreciate you kind of acknowledging the scope of all of that together. And such a, I'm really just also struck by you know, by the real importance and initiative of where that came from, right? This came from a conversation between people with FASD saying, hey, there's something here, you know, that people aren't paying attention to, and that the real importance, right, of engaging and partnering with people with FASD to help find out where are the gaps, like where don't we know enough, you know, from the experts, people who are living with this every day. So thank you for also just re-emphasizing that importance, you know, both as it relates to pain, but beyond. So thank you for that. So I'm just going to introduce our final speaker today, who is CJ Lutke. CJ was diagnosed with fetal alcohol syndrome when she was a baby. She was adopted by her foster family when she was 5, along with an older brother and sister who also have FASD. She's a member of the Adult Leadership Committee of FASD Changemakers and guides much of its work. CJ is a well-known speaker on FASD, having presented it at and participated in many conferences, seminars, training sessions, and other events for many years, sharing her experiences and what she has learned living with FASD. In 2016 and 2017, she was co-lead of a groundbreaking Changemaker study on the health and physical issues of adults with FASD that has received wide international attention. She's currently one of the co-leads for their new survey on the quality of life for teens and adults with FASD. And CJ believes those with FASD must change the future, challenging perceptions and possibilities and outcome. CJ's goal is to help others with FASD find their voice and to help society understand that we are greater when we are united and work together. So perfect in following right after Myles' presentation. So I'll turn it over to you, CJ.
Hello. So Myles talked a lot about the stats, which are really important. But what my talk is going to be about how we're perceived in the medical field to people who don't know anything about FAS, and the obstacles that we experience with pain, and interpretation of pain, and how we are seen. So like he said, over 50% of us report a high pain tolerance. I'm included in that. Myles is included in that. So many people, like all my siblings, are included in that. So when I was younger, you know, my siblings and I would play hockey or football, and we would be what other people can do really rough, like really rough. We'd leave the field with bruises, and we'd be like, whatever. And when a non-alcohol affected child would play with us, which was very rare because word got around that you want to play with us because we were so rough, we didn't understand why they were crying, why they were being such a wimp. So it's not only our perception of pain, it's our perception of pain in other people. Our quote empathy can look a lot like sociopathic behavior, like we don't care. But we do, we just don't understand. It's taken a long time, personally for me, to understand how others perceive pain. So if you're not understanding how others are perceiving pain in the world around you, you're going to be perceived as this not caring person, which again, probably, you know, feeds into a stereotype that a lot of people have about FAS. We do experience pain, and not like everybody else. I know a few people who have low pain tolerances, and they have been accused of pain-seeking medication because their pain just, it won't go away for some reason, or they just feel it so much more intensely. And you know, they're not getting their pain seen to because they're complainers and whiners, and they go to the emergency room, you know, because they don't know where else to go. And the emergency room, people are just tired of seeing them. The medical care that we get, because I'm going to be talking about the medical care that we get, is also hit or miss, mainly because this study has come out in 2017. People didn't look at FAS as a body syndrome. So they just looked at it as a mental syndrome. And I know from, you know, experiences from everyone I know have gone to the hospital and said, you know, I have FAS, this is a medical condition. Doctors will dismiss it. Nurses won't know what it is. And nobody will know quite how to help or how to deal with that as a medical issue. They don't know how it affects you medically, they just know it's there. Which again is a gap in, it's a need to be filled, considering we're the highest population for disability. We're being, you know, more than autism, more than other things. And we're a big population of people who are contributing to the healthcare, quote, burden. Once you're in the hospital, I don't know if Myles, I can't remember if he's discussed this, but the sensory issues around hospitals and how we're perceived. I know that when I dislocated my knee a couple of years back, I can't remember, maybe 5 years ago, it had gone in and out a couple of times. Like the first time I did it, it went back in, and I thought I broke my leg because I was 12 and it went in and out, and I felt everything collapse on one another. But like 2 hours later, I was participating in gym, no problem. My mom took me to the doctor the next day because I was limping. He said, dislocated it. I'm like, okay, didn't know what that meant. It's another perception issue. I didn't know what that meant. I wasn't feeling enough pain for anyone to say, hey, don't play gym. I could have really hurt myself. And those are really serious things. I know that my brother has had a heart attack at age 23 from the flu. And the only reason he went to the doctor the second night of chest pains is because he couldn't breathe. The first night he rolled over and ignored it. Sorry, I have notes. The last time I dislocated my knee, it wouldn't go back in. And I was more concerned about missing work. I missed my bus. I phoned into work before I phoned in for help for my knee. So when we finally go to an emergency room for something, or someone says you have to go to an emergency room, and we're not looking like we're perceiving that we're not feeling the pain that we should, we get dismissed, and a lot more complications can happen. I know that when I did finally get to the hospital because somebody called the paramedics because I was lying on the side of the road and my knee wouldn't go back in. And I actually had to phone my mom and I'm like, well, it won't go back in. She says, this is when you need an ambulance. Again, I didn't know I needed an ambulance. I just knew that it was out and I didn't know what to do. So these are all things that contribute to health issues. We don't know what an emergency is. When it is an emergency because of pain, what do? Like, we don't want to be considered like wimps. We don't want to be considered complaining. So those are really important issues. Once I was in the hospital, the paramedics dropped me off and I told them in the ambulance, hey, I have FAS. This is what it means. One of the paramedics told me, well, you don't act like anyone with FAS. I to this day, I'm like, well, I didn't have my handbook. You know, like a lot of people have preconceived notions of what FAS looks like, and they're conflating it with mental illness and stress and all sorts of other factors that are not FAS. So again, their perceptions of us during an event are very misleading, and we don't get the health care that we need, and we don't always know how to verbalize it. For the chronic ear infections, another interesting thing about that, and we missed it in the health survey, is that very few people that I know with FAS get fevers and temperatures. That's the body's first reaction to, hey, something's wrong, but we're not getting them. So I wonder what's going on there. I think that's it. I hope I've covered everything I wanted to cover. Sensory issues. I think we need advocates as well. Doctors need to do a lot more research on, or at least pay attention to people with FAS when they come in and say, hey, I have FAS. They need to be looked at differently. They need to use language differently. When we go into the hospital, they use the pain scale. Everyone I know who have had that pain scale, they're like 5, 2, 6. They don't want to go 10 because they're over dramatic. They don't go 1 because they feel pain. It doesn't mean anything. We all know the number section of our brain is like messed. Why do we use this pain scale? It's not an accurate representation of what we're feeling. So I think those are some issues that people really need to pay attention to. We need advocacy. We need somebody in there who knows FAS, and we need language that is very simple and not metaphorical or euphemistic. Thank you.
Thank you so much, CJ. You touched on so many really important things, and I think really highlight pain is complex, right? I mean, I think between all of the speakers we've heard today, sometimes we talk about pain in this, what we call a biopsychosocial, let's add systems framework to this, right? It's impacted by kind of our biology or physiology that Dr. Sue touched on. But it's also, and the stress response, kind of what else is, is happening, but the social context within which this is happening too. You brilliantly highlighted, that the challenges in accessing care and talking about, how health professionals are interacting or stigmatizing or dismissing, really important aspects to that experience as well. Hopefully we can keep the conversation going kind of through social media and other continued work together. Thanks for joining us today.